it's great to be amongst friends who are believers in partnerships. Or most of the time I spend with colleagues who sometimes don't have the same belief in partnerships. And I think that's one of the things that I wanted to bring to the table also, is that our responsibility when we're in rooms where colleagues may not be as convinced on the role of institutional health partnerships. And that comes with a responsibility, because one does have to forge that belief, and that belief has to come from evidence and has to come from improvement that was being mentioned this morning. So in the next 20 minutes or so, what I've been asked to do is to talk a little bit about quality and what it means potentially to health partnerships. Before even starting, should emphasize that most partnerships are really focusing in on quality. But I'm just going to unpack what the current global thinking is around the subject. So quality, right from the beginning, to emphasize, we're not inventing something that's new. It goes back a long, long way, clearly. And in fact, it goes back millennia, because whenever human beings have treated other human beings in whatever shape or form, there has been some emphasis on the quality of that service being provided. Whatever you think about traditional or complementary medicine, this history goes back millennia. But let's come to the modern era, and I think most of you will be familiar with the different domains of quality that have been emphasized at different periods, going back to Don Abedian in 1988, but all the way to some of the work that WHO and OECD have done. The emphasis here really isn't on going through those domains, but the emphasis on this slide is to emphasize that there are multiple domains, and the debate on the domains of quality have really unfolded over time. But really, this definition of quality has often been seen in various documentation on quality. This is the definition from the US Institute of Medicine: the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And that definition implies that improving quality is change. And again, this was what we were listening to this morning, that it's multidimensional, and it's the product of individuals working with the right attitude in the right system. So trying to really unpack this in the context of a partnership. And with all of those domains, we do see a consensus emerging around three core domains: that of effectiveness, that of safety, and that of people-centeredness. And if we remember that triad, and if you think about a partnership, clearly there's always going to be work on enhancing the clinical effectiveness. There's always going to be some work on enhancing safety. And ultimately, and this is also something that David and Rory have mentioned this morning, is that there's always a focus on making that service more people-centered, recognizing that timeliness, equity, integration, and efficiency are also key considerations. But I come back to this same principle, that it implies change, it's multidimensional, and it involves individuals working with the right attitude in the right system. This has been mentioned already, but it's important to really bring that SDG 3 to life, is that when in 2010, the World Health Report really put this out there in terms of universal health coverage and the three dimensions, I had the privilege of scribbling down this sentence on the right-hand side, on the top, from our previous Director General, Margaret Chan, who said these very simple sentence, but it just cuts to the chase. What good does it do to offer free maternal care and have a high proportion of babies delivered in health facilities if the quality of care is substandard or even dangerous? Very simple sentence, but I could explain that to my mother. These data at the bottom are from India, and essentially emphasizing that institutional delivery, which has been a success in India, did not lead to the decrease in maternal mortality ratio that would be expected. Again, bringing the science to that sentence. So this reaffirms on a conceptual level, very simply, that universal health coverage has to have an emphasis from promotion to prevention to treatment to rehabilitation to palliation. So that's the other thing, that the frame of mind often gravitates towards treatment, but we really do need to take a public health approach and go all the way from promotion, and placing quality at the heart of this, with people at the center. So that's something that we tried to instill within the debate related to universal health coverage. And we were very, very pleased that when all of the global dialogue that David was alluding to landed in a safe space of SDGs, that the definition of universal health coverage had quality well embedded within it. And importantly, that target 3.8 really emphasized the necessity to look at quality within the context of universal health coverage. Just in the last couple of months, there have been 3 global publications on affirming quality as central to UHC. I'm going to go through some of the findings from one of them. 3 sequential global publications, all affirming this point. The first one was the WHO, World Bank, OECD report. The second one was the National Academies of Science. Many of you will be familiar with the previous US National Academies of Science report on quality, which really shifted the needle on quality. This report was focusing in on crossing the global quality chasm. Most recently, the Lancet Commission report on high-quality health systems. Coming to the WHO, World Bank, OECD report, I often emphasize that it's very rare that 3 heads of organization come forward and get behind a specific point. But you can see that my big boss, alongside the head of the World Bank, as well as the head of the OECD, strong, united voice for quality. And it's really unequivocal. Without quality health services, UHC can remain an empty promise. So making very clear that that is the case. But it wasn't just rhetoric. So this report, I encourage you to have a glance at it, also lays out some of the key quality interventions that countries can take on board in defining their pathway on quality. And it blocks it into 4 blocks. I won't go through all of the different blocks, but again, it's worthwhile thinking about this when working in partnerships. So the system environment, and this is really focusing in on registration and licensing, external evaluation and accreditation, clinical governance, all things that I think all of you are very familiar with. But importantly, and this is something that David mentioned, is the training and supervision of the workforce, core consideration for a partnership. Second big block is reducing harm. No surprises there. Safety protocols, safety checklists, adverse event reporting. Third, improvement in clinical care. Again, no real surprises. Clinical decision support, clinical standards, clinical audit and feedback. Really important areas within improving clinical care. And finally, something that is considered a quality intervention, patient family and community engagement and empowerment, really changing that dynamic from a focus on demand, not just supply. So thinking about health literacy, shared decision-making, and all of those pieces that often get neglected when we're talking about quality purely from a facility or a health service side. Another very important point that has actually already been alluded to is that the call for action within this global report emphasizes that all governments should have a national direction on quality through a policy or strategy. Now, why is that important? It comes back to that iterative nature of change, but having the government clearly outlining its pathway towards quality, recognizing that it's not an overnight affair. How is that linked through to health partnerships? The second part of my intervention this morning will focus in on that. Often, when countries are developing their national directions on quality, you get the situation where some really clever people sit in a room and develop a policy, and that somehow percolates into a strategy, and at some stage goes down into implementation. The work that WHO has been doing on this subject has really been trying to change that paradigm and place implementation experience at the top. So policies and strategies on quality or improving quality really take into consideration the frontline realities. And this is particularly where the role of institutional health partnerships come in, because it's through those partnerships that often countries can understand the realities that they're facing, including some of the ugly realities that are faced in different settings, so that the policy and strategy is not merely an aspirational document, but it is brought to life through implementation experience. Very important point related to institutional health partnerships. Moving into the realm of twinning partnerships, let's think about quality improvement. Now, again, through the decades, multiple definitions of quality improvement, but this is a simple definition that hasn't made its way into an openly accessible document as yet, but it's from an internal WHO working group. But it's a simple sentence, again, I can explain to my mum. The action of every person working to implement iterative, measurable changes to make health services more effective, safe, and people-centered. And those two words, I think, are the most important here, is iterative and measurable. So the whole concept of this long-term change approach is embedded within this quality improvement piece. And also, it emphasizes, if you remember, the three domains that we were talking about convergence on: effectiveness, safety, and people-centeredness. So why would a partnership focus on quality improvement? Well, first, it's quite intuitive to decrease the level of harm. So there's the safety dimension. It's applicable to clinical and non-clinical areas. So this is where the interface between the clinical and managerial becomes clear. But it also can include parts of the system which often are neglected, like cleaners are part of quality improvement initiatives often, especially in the context of infection prevention and control. It can give profile and human resource dimensions to the effort and quality improvement. It potentially has that long-lasting impact related to sustainability and spread. And it has an opportunity to lead and learn with a focus on improvement. So this long-term piece that we were also hearing this morning, and building in some of the quality aspects into the approach and delivering some of those quality interventions, but testing those through partnerships. I think most of you, or some of you at least, would be familiar with the three objectives that some of the WHO work related to twinning partnerships for improvement has focused in on. Very simply, three objectives: a strong partnership, a focus on improvement, and ensuring the third objective, that the partnership is informed by and informs the national direction through a focus on spreading the learning that emerges from the partnership to other parts of the system. And I've left a few copies of this document in the front there, but the emphasis really is to take a systematic process through a validated mechanism, which is exactly how I think most of the partnerships in Ireland have been taken forward. But this at least gives it a certain architecture within which this can work. Who benefits from twinning partnerships? I don't think I need to explain that to this audience, but you can see that the beneficiaries of these partnerships are much beyond and further than the actual institutions that are involved in the partnership itself. I mentioned this systematic six-step process, this focus on partnership development, really emphasizing a strong focus on that, emphasizing the needs assessment, a gap analysis, action planning, action, evaluation, and review. All 6 steps have been unpacked within the resources that have been developed, and we've benefited hugely from the wisdom of the ESTHER group They've contributed heavily into this document, but also others across the world, including ESTHER that David already mentioned. I wanted to touch on something that is very dear to my heart, and David already mentioned this, the concept of innovations through partnerships. So we cannot forget that the global flow of knowledge, skills, and ideas has been a defining feature of human progress. And health systems of today didn't just come about overnight. It's a culmination of centuries of global innovation flow, often flowing from Asia, Africa. And the point here is that innovation can flow in all directions, north to south, and south to north. Again, the partnership community, those that are sitting in this room, have a huge opportunity to be advocates for this movement. And it's very much related to SDG 17. I'm trying to look at them with that. There you go, I can't see it. Just invisible, but highly evident, SDG 17. So this is an area that partnerships can do groundbreaking work in. And it's not just a concept. There are examples already percolating the literature on how systems in so-called developing world countries are influencing systems in so-called developed countries. So the example of community health worker models from Brazil influencing the worker model in North Wales. The example of surgical techniques, particularly utilized in low-resource settings, that are being examined, at least in the first instance, by surgical community in different parts of the world. Hospital accreditation even, the whole concept of lessons from applying accreditation mechanisms in low and middle income countries. There's a number of these examples that are starting to percolate the literature, and the partnership community can add to that. So I wanted to stay as focused as possible so that we could have some room for potential questions. But I just wanted to end with just a few key points. So the first big point to emphasize is that we do need to ensure quality is recognized as a fundamental precondition of service delivery and health systems, keeping at the heart of UHC. So the reason for that perhaps we should be considering is that each national authority is developing their pathway on universal health coverage. And the pathway often needs to consider quality within the design phase or the refine phase. So Ghana, at its 10th anniversary of the National Health Insurance Authority and the National Health Insurance Scheme, said they were very humble in their analysis. They emphasized that in the design of their famous universal health coverage system, they had not paid attention to quality within the design. And I had the privilege of delivering the keynote there. And what they were emphasizing, parliamentarians on both sides of the House, is that they need to redress that. We cannot afford to do that in all countries. The design phase of UHC has to embed quality. We need to build in quality improvement into the core of institutional health partnerships. And the reason I would advocate for that is really listening to the colleagues this morning. So building in the architecture for change, because quality and quality improvement is all about change. And how can we embed that within the architecture of institutions, but importantly, the architecture of health systems? The third point is to ensure a strong linkage between the partnership work and national direction on quality, to think sustainability right from the outset. So, for example, the hospital in Liberia that received the first case of Ebola and unfortunately was unable to detect and respond to the Ebola case, established a twinning partnership with a university hospital in another part of the world, in Japan actually. And the Ministry of Health were directly examining this to inform their national direction on quality. They chose the hospital clearly for a reason, because they wanted to make sure that the first hospital on the border with Guinea is able to detect and respond any further outbreaks. But importantly, they were also setting their national direction on quality. So here's the blending between institutional health partnerships and national direction. And finally, when we're developing solutions in these institutional partnerships, let's link it up with the global knowledge architecture. We do need to be able to be honest. Partnerships don't always work. There are huge problems that we face in implementing partnerships on a day-to-day basis. You guys know that better than I. But in those partnerships, those problems often give us more juice than the solution sometimes. And so having that openness, the culture of learning, and making sure that the local learning feeds into more global learning is perhaps really another key contribution that the institutional health partnership movement can provide. So thank you for listening. I'm really pleased that 17 SDGs are all around the room, but just to emphasize and reiterate what David was highlighting, MDG 8 was never unpacked properly. I mean, I'm just being a little bit controversial there, but SDG 17 offers us an opportunity to rethink and really push on the different targets that are placed within SDG 17. The institutional health partnership movement can really bring life to what is often a reasonably general discourse on partnerships. So unpacking some of the targets on SDG 17, linking it up with SDG 3, but also thinking about all the different SDGs that institutional health partnerships touch on. Because I bet if you analysed all the partnerships in Ireland and you did a quick analysis on which types of SDGs were being impacted on, it would certainly be far beyond SDG 3. There'd be lots of different pieces within the jigsaw that we could unpack. So thanks for your attention.